All right, good morning, everyone. Let me know if you can hear me there in the chat. All right, good morning. Or monitoring, that's fine too. Whatever you're experiencing this morning. Yes, hello, good morning. Hopefully the test went okay. We'll talk a little bit about that once we get into it. To give everyone a few minutes to get in. So funny, I see the name Vlad all the time now because my kids are watching this like YouTube channel called Vlad and Nikki. These little kids always getting into antics. She watches the same videos over and over and over again, so I'm very familiar with those two children. Yeah, I guess like they're like ultra rich because they have a huge following, and I mean, just looking at the production value, it's like, man, I could probably figure out how to do that, but I think it's hard to get into children's YouTube, and something about exploiting my children for monetary gain sounds a little ethically sticky to me, so I dash those dreams now just do teaching online. Although I'm at like 450 subscribers, so that's kind of nice to see. That's good morning. Good morning. I think. Let's see. Yeah, that's no problem. Glad you guys appreciated that. You know, we gotta be flexible during these unprecedented times, so it's proud to meet with you guys. I'm glad more people got to take advantage of it. Yes, hello. And again, if you have any questions or anything, feel free to post them up in the chat or on the sticky board. Well, there's a better name for that than sticky board. I'm going to stick with that for now. All right, well, it is 9 o'clock, so I'm going to go ahead and get started. Thank you all for joining me today. So hopefully the quiz is okay. I'm going to start recording, actually. All right. So in terms of the test, again, I have to go through and validate it based on the stats and whatnot, see if there's any missed keys or anything like that. So I have a couple of questions about the exam on the sticky board. I'm going to hold on to those until next week, so sorry to slow that down, but I have to make sure the test was valid and all that before I can address anything. If you have specific questions about the test, feel free to email me separately. That's totally fine, and we'll figure all of that out. Hopefully it was not too bad. Hopefully it was representative of the material we covered, but other than that, as always, feel free to post up your questions, and we're going to get started with the next section here, which is our geriatric and neonatal / pediatric sort of pharmacology. We're going to probably be able to get through the geriatric section. I don't know that we're going to be able to get through much of the peds today with the hour that we have, but we'll catch back up in the following week or so. So let's start off by talking about our geriatrics. Who are we referring to? Basically anyone 65 years of age or older. These stats are a little old, but you get the idea that we're dealing with more and more elderly patients. Generally life expectancy increases, although with the Rona, who knows how that's going to go there, but we'll see. But we're going to be dealing with geriatric patients almost anywhere in where you work, unless you're specifically pediatrics. You're probably going to run into these patients. And so, yes, you're very welcome, Shamira. So you're going to find that they're going to have a lot of issues in terms of like complex medical issues. They're going to have a lot of medications that they're on, but also not only that, but we're looking at their psychological capabilities. We're looking at their functional capabilities and see how that's changing over time. So obviously you want to do things like increase quantity of life for these patients, but in a lot of cases you may need to look more at the quality of life that they're experiencing and how our medications can affect that. And so this is why it's really important to do good assessments for these patients, which is what you're learning about. And to help out with that is this idea of the interdisciplinary teams. I'm sure many of you have heard this term of like interdisciplinary medicine and things like that, or interdisciplinary practice, but it's really critical that we take advantage of this when you can. Making sure that you're having your dietitians help out, make sure your pharmacists and your nursing people and your mental health counselors and all of that, everyone has their own perspective, and it gives you a much better sort of holistic sort of view of the patient and what is really going to be in their best interest there. But looking at some of the things we're going to be looking at, including sort of their activities of daily living. So what can they do, what can they not do? And you want to look at changes over time too, to see okay, well, they used to be able to get up and go grocery shopping, but now they can't really get out of the house because of mobility issues or something like that. You want to look at changes over time, and even things like pain. When you're trying to assess for pain in these patients, it's all well and good to ask what's your pain on a scale of 1 to 10. But really, a better thing to ask is, okay, well, can you go to work? Can you go out and garden in your backyard? Look at functional changes to see, okay, well, how effective is my medication being in terms of actually getting them just more functional? What can they actually do, right? And so just to get into some of the different assessment options we're going to do here, and of course I covered up part of my words here, we get the idea. Looking at their nutrition is going to be really important in terms of not only how the medications are going to be working with things like protein stores and all of that. We're going to see big changes in volume distribution for patients who are malnourished, but also in terms of what they're intaking, how that might interact with medications they're taking at the same time. For some of these patients, it could be a dentition issue they're dealing with. It could be related to decreased appetite, maybe related to some mental health concerns. We see constipation with a lot of different conditions that is going to be exacerbated by some of their medications. So you want to kind of assess for all these things because, again, you got to start with good nutrition. Otherwise, you can't really have very much health unless you have that sort of figured out. And again, it could be limited access to their ability to prepare food or even get food in the first place, depending on the situation there. And so one of the things you can do is ask them to get kind of a good 24-hour sort of recall of what are they taking in, including their food, their drinks, any dietary supplements and things like that. Herbals and dietary supplements are things that a lot of patients may not be upfront about, not necessarily due to any sort of maliciousness or anything like that, but they may not think about telling you that. So if you ask the question, then you should at least get some sort of answer out. When you talk about drinks as well, are they getting good water intake? Are they dehydrated sort of chronically? And what are these kind of what's going on from that standpoint? And so, asking about things like, okay, well, has any illnesses or conditions actually changed their ability to, is it change the amount or kind of food they're able to consume? That can be important. Are they getting vegetables and fruits and things like that? Because, again, having a good amount of fiber in your diet is also very important, especially for GI health and things like that. So these are things you're just checking out, right? In terms of alcohol consumption, I think this is a really important one. I think as everyone has seen with the lockdown and whatnot, they classified liquor stores as essential businesses. And a lot of people are like, oh, haha, people got to get their alcohol, but it's true. It's like it's one of those things where there's a lot more sort of undiagnosed patients with alcohol use disorders than you think, and if they stop drinking suddenly, it's going to be bad for them. They can have significant withdrawals. But you want to ask about, okay, how many drinks do you have in a night, or how many drinks do you have in a week? And when they say, oh, I have a glass of wine a night, like, well, how big is that glass? Because not all glasses are created equal. Is it the entire bottle? And so sometimes I'll try to get one past you by sort of obfuscating the points here, but those are good things to ask about. Who's feeding them? Are they preparing food for themselves? Are they, these patients are usually on a fixed income, so are they able to even have the resources to get their food? Are they making decisions between getting their medications or food, which is a common one you'll see there. Check out changes in weight over time. You'll be asking about this for a lot of different conditions, but one of these happens to be with their nutrition standpoint. So then, in terms of laboratory assessment, kind of once you have that nutrition stuff down, then looking at the laboratory tests. And so I'm sure you guys have been, actually, I'm not sure about your schedule right now, but have you had like a Clin lab class or something where you go over like different types of labs and all of that? You can just answer in the chat there. But basically what you're going to find is that oh, you haven't had that yet. Okay, that's good. I'll talk about it here. So basically, when you're looking at different labs you can get for patients, there's a variety. There's all kinds of different things you can collect on them. One of them is called a CMP, which is a complete metabolic panel. And again, I apologize if this is repeat for anyone. There's also a BMP, which is just a basic metabolic panel. It gives you some electrolytes and their glucose levels. But CMP is going to be more complete. That's what's in the name there. And so it gives you more information, not only in terms of kidney function and electrolytes. That's where we get our creatinine from, is from those metabolic panels. But also like liver function is going to be on there. Things like their protein stores, like albumin and acid-base status. And so you'll find a whole lot of things that are going to be included on here that kind of give us an idea generally of that patient's health, right? So see if their electrolytes are in check, see if their glucose is good. We can also look at things like their lipid panel to see, okay, are they, being compliant with their hyperlipidemia medications. We can look at things like the A1C, which is sort of like a running average of their glucose for the past 3 months. A lot of times you'll have patients who are diabetics who are not being compliant with their medication and diet regimens. And so before they come in to see you or get their labs drawn, they'll go ahead and take their insulin or whatever to make sure their glucose is under control. But then you check the A1C and it's still like super high. And okay, well, yeah, that one glucose level was good, but the past 3 months have not been quite so good. So sometimes they will try to get to one past you again by means of that. But other things like the CBC, you're looking for anemias, you're looking for their platelet and white count, see if there's anything going on there. All these things are really, really helpful to give you sort of a more clear idea of like kind of what's going on with the patient. So you're talking to the patient, you get an idea of their functionally what's going on with them, and then you're also going to be checking out from the lab standpoint to see, okay, what's really happening here. And so then that's kind of the assessment portion of it. But then also when you're asking about their medications, you're going to find that their list tends to expand exponentially as time goes on. And so polypharmacy is generally the rule for a lot of these elderly patients. And so when I say polypharmacy, that basically means taking 5 or more medications regularly. And so what are the reasons for that? Well, a lot of it's related to the fact that they're living for longer. They're accumulating more chronic diseases as time goes on. And not only that, but if you're looking at the evidence-based practice, you're going to find that they are, over time, they'll add more medication. So, if you have someone who has an MI, and we'll learn this next semester, they need to be on a beta blocker, and they need to be on aspirin, and they need to be on an ACE inhibitor, and they need to be on statin. And you can see how the list will go on, and that's all appropriate. That's based on the evidence. But, if you have someone who has osteoporosis, osteoarthritis, type 2 diabetes, hypertension, and COPD, which is completely realistic that would happen, they might be on like 12 different medications here. And they're taking it 5 different times a day. Like, I can barely take a multivitamin 1 time a day consistently, and you're expecting these people who may have impaired, mentation to actually be able to keep up with this stuff. So it can be difficult for them. And so, when they're being non-compliant, you don't want to just sit there and judge them and say, well, you should be taking your medications. And realize it's tough. It's a hard thing to do. Not only that, but also hospitalizations can be tough too, where, more often than not, when they come out of the hospital, they're on more medications than what they were going in, right? So these lists just get totally out of control after a period of time. Yeah, Josh says, I have a hard time taking one medication twice a day. Yeah, it's tough. I mean, it's hard to be in the human, as it turns out, right? So what are the consequences of that? Well, we're going to see more adverse drug reactions. The more medications you take, the more likely they are to start interacting with one another, just by chance alone, as it turns out. And a lot of times they don't know that they're experiencing an adverse drug reaction. They just may think that, okay, well, this is just the new normal for me now, or they just get dizzy when they stand up now, and that's just normal. And unless you really educate them well, they may not be able to, know that sort of information to say, like, okay, I am having a problem with my medications there. And so falls tend to be a really, really big risk for this population here, especially if they're on anything that can depress the CNS, anything that can lower blood pressure, tends to cause a host of these issues. So that way when they stand up, they get dizzy and they fall, right? So it's one of those things you're going to see that, when they fall, they have a fracture. And then when they have a fracture, then they're going to be, laid up in the hospital for a while and possibly have to go to surgery. And, there's a lot of morbidity and mortality that comes around with falls for these patients. So it's really, really important that we take that into account and try to mitigate that risk as best we can. And then, as I mentioned, just with the complexity of the medication regimen, you're going to see decreased compliance pretty regularly, right? And so in a lot of patients, you can ask them, well, are you taking your meds like you're supposed to? And they just say yes, right? And they may not be telling you the truth there. Because, again, they don't want that judgment from you. And you can tell them, hey, I'm not going to judge you, but they still feel that pretty regularly. So because you're an authority figure, right? You got the white coat on. They think you're the boss, and so they're going to get in trouble if they're not compliant. But one thing you can do to help out with that is ask them, just say, tell me how you take your medications, and see if they're, if they have a good understanding of that. They're, being able to remember, okay, I take this one twice a day, I take this one 3 times a day, et cetera, et cetera. And so, talking about that the decreased compliance, there's a lot of reasons for that, not just, their ability to remember to take it, but there's other things too, like, the economics of it. If they can't afford the medication, they're not going to take it. But they may try to do things like extend how long that prescription is going to last them. So if it's something they're taking once a day, maybe they'll do it every other day just to make it last for 2 months instead of one. You can find that things like visual impairment can be really tough. If they can't see or read the label to know when and how to take it, things like that can be important. Decreased swallowing ability. We see that a lot with patients with Parkinson's. As it gets more progressive, they have a lot of dysphagia, and it's very difficult for them to swallow things. You have to consider, okay, well, they can't take tablets anymore. Do I need to switch them over to sort of a liquid medication as an alternative? A lot of these patients are pretty frequent flyers in the healthcare system, and so you're going to find that decreased venous access comes along with that, just due to getting frequent sticks, and they get scar tissue that develops over common IV sites, and so that can be difficult to get IVs even started in the first place. And not only that, but you have to consider, well, how willing is the patient even to adhere to treatment? Because if they're at the end of their life and the medications are causing them more grief than not being on anything, they may just decide not to do that, right? So you have those patients who are old enough to where they're like, nah, I'm good, And so when we're talking about that, we're talking about palliative care. We're talking about, a lot of people don't like the term hospice. A lot of people think it's kind of like a death sentence. So we say palliative care. I think it's a better term to use for that. But when they're at end of life and they have less than 6 months to live, we have to make sure we're prioritizing their treatment based on what is important to them. So not just looking at life extension and the quantity of life they have left, but as they get over here towards the end of their life, you're looking more at quality of life here, this palliative treatment. And so, for instance, my wife, she did her second year residency at the VA. And so a lot of her job, she's a pharmacist as well, a lot of her job was taking these patients who were at the end of their life and just making them comfortable, getting their pain medication regimen under control. And you'd have people with COPD that are just having such severe dyspnea 24/7, they're just gasping for air, and giving them things like opioids to help try to depress that respiratory drive enough to where they are comfortable, right? So it may not do anything to increase their lifespan, but it certainly will make that last bit of it a little bit more comfortable for them. And then certainly focusing on the family after that occurs, because again, everyone becomes a patient at that point in terms of like mental health and all of that. So let's look at some of the normal physiologic changes we find in this patient population. Certainly in terms of cardiac, on the cardiac system, we're going to see things like increased blood pressure. We're going to see more impedance in terms of left ventricular function. We're going to see reduced heart rate normally occurring here. The kidneys are particularly important in terms of pharmacology because of the fact that we're going to see overall decline in GFR, which we talked extensively about during that pharmacokinetic section. And so you're going to see that as the GFR goes down, we're going to not be able to filter drugs as effectively, and that's going to lead to things like increased half-lives of medications. We're going to see that they can't maintain their acid-base status as well anymore. They can't regulate that as well, and so that can be problematic for a host of reasons. And so you can see someone, like a 20-year-old developing metabolic acidosis, and they can handle it much better than a 90-year-old can because their kidneys are much better at able to regulate that excretion or holding on to that bicarb much better than the elderly patient can. And here, looking at this graph, you can see that there's going to be that steady decline. So we assume that a 90-year-old is not going to have perfectly functioning kidneys. Like I mentioned before, even if they have very little muscle mass, as we'll see, they're not producing a lot of creatinine. It doesn't mean that their GFR is fantastic because their creatinine is 0.8. It just means that they don't have a lot of muscle mass left to actually produce that. We know that their GFR is going to be declining as they get older. In terms of GI changes, we're going to see overall that this won't have a huge effect in terms of actually how the medications are absorbed or how they are going to be processed by any means. But we can see that certain factors do play a role. And so, for instance, like with the liver, when you have decreased blood flow going to the liver, you're presenting less drug to the liver to be metabolized, and that can slow things down, right? That can slow down the metabolism and elimination there. Also, this decreased motility can actually slow down how well drugs are being absorbed, and it takes longer for that to occur because things are just not moving quite as quickly. And you're going to see constipation is going to be a huge issue for these patients, not only in the fact that if they're taking a lot of calcium, that tends to be constipating because they're worried about osteoporosis, but many medications can also do that as well. So if they're taking opioids, that can do that. If they're on a calcium channel blocker, if they're on an anticholinergic, like these are all classes that we'll learn about in the upcoming semesters that can all cause constipation, and patients may be on all of them at the same time. I have a distant family member who was on many chronic medications and whatnot, and they were developing some stomach cramps, and they were looking for a medication to treat that. And most of the medications we use to treat constipation tend to slow down motility because it's trying to keep that muscle from contracting. And so she was asking about medication she could take. And then, common reason patients get crampy as well is because they're constipated. So I asked, well, when's the last time you had a bowel movement? And they're like, oh, it's been like a week. I was like, well, shoot, no wonder you have such bad stomach pains. Like you're FOS, you're full of stool, right? And so we realize that giving a medication to slow that down even further is just going to compound the problem, right? So what she really needed was a laxative in order to get things moving along, and that all of a sudden decreased all of her cramping. It was crazy how those sort of things tend to work. So as I mentioned with absorption, no major changes occur here. However, you will see dietary changes and things like that that can certainly play a role. So for instance, if you have someone who's taking antacids regularly for heartburn and dyspepsia, you can find that can affect how well drugs are absorbed by modifying that pH in the stomach, for instance. Or you may find that if they're taking in a lot of calcium, that can then interact with many other medications. Say, for instance, you have someone who has anemia, and they should be taking iron supplements, but then they're taking that along with their calcium supplement. Those two tend to bind up one another, and so you'll never fix that anemia because the iron is never getting absorbed in the first place, right? So that's a big issue. Not only that, but you can have patients, especially diabetics, who have impaired gastric emptying, it's called gastroparesis, and that can also slow down absorption as well. So total absorption tends to be the same, it's just kind of slowed down. In terms of distribution, this does have a large role to play here with these elderly patients, because overall you're going to find they're going to have reduced lean body mass. I don't know too many 90-year-old bodybuilders by any means, but you're going to see they're certainly going to have reduced body mass as opposed to younger patients. And overall reduced body water too, and so you can certainly see that will play a role in terms of volume distribution. But looking at this chart here, if you're comparing like a 20 or 30-year-old to someone like you compared to an older adult patient, someone who feels like me, right? Just kidding. You'll see things like the body water goes down. So there's less volume for those drugs to partition into, so maybe that reduces the volume distribution for hydrophilic medication, right? Looking at things like body fat percentage tends to go up. You're going to see that that can lead to increased volume distribution for lipophilic medications there, right? Josh is asking, is it reduced body water because of the lean body mass? Some of it is related to that. It could also be related to water intake. It could be related to many different things. It tends to be multifactorial in a lot of instances there. But you can also see things like, serum albumin is going to go down. And we know that protein binding in the blood is also going to play a role with volume distribution. If we have decreased albumin, that's going to allow for certain drugs to then partition out into the tissues more so more so in the adipose tissue and whatnot. And then, of course, kidney weight and liver blood flow is also going to be reduced as well. So kind of everything is slowing down. Metabolism, excretion, drugs are going to tend to be have a higher volume distribution if they're lipophilic, and have a lower volume distribution if they're hydrophilic. And so looking at protein binding, as I mentioned, those decreases in albumin tend to either be related to nutritional status. Most often, as their consumption of nutrients goes down and protein and whatnot, you'll see that serum albumin tend to trend down as well. And that can have a really big effect. So if you imagine looking at two patients here, one has a normal albumin level, one has a reduced albumin level. Imagine if I were to have, and again, bask in my wonderful art skills here, you can see. So imagine I have two patients that are like the same size, and they both have, they're taking the same medication and whatnot, but one of them has a lower serum albumin level than the other. And let's say, for instance, they're on a medication that is like 90% protein bound, right? So let's say this is the upper 10% here. And so this is what drug is basically bound. So this portion here is 90% bound to the albumin. And this portion here is going to be free. And we mentioned that free drug is pharmacologically active. Please don't show this to Dr. Murray. She's probably going to think you have like an elementary school student, probably even like preschool, as your teacher here with my art skills. But anyway, so let's say only that 10% is actually pharmacologically active for them. Well, what happens if you have someone who's getting the same dose of drugs, so they're getting the same amount in the system, but maybe they have only like 70%, or maybe they have a reduced albumin to where now like only 70% of that drug is protein bound. That now means that 30% is free and is able to, one, partition out to the tissues, so you can see that increases volume of distribution, but also you're going to see a big increase in the amount of pharmacologically active drug that can interact. And so that can really play a big role to where even if a patient has a normal level, quote unquote, within the therapeutic range, because when you measure the blood, you're going to measure both bound and unbound drug, they may have toxicity related to that because they have so much more free drug there. This is a common thing that happens with a drug called phenytoin, which we use to treat epilepsy, is if you have someone with low albumin levels, they can have a normal serum level, but they can have a lot of free drug floating around causing dizziness and ataxia and falls and all of that. So that's going to be a big factor for these patients with sort of chronically low albumin levels. In terms of clearance, this is something you have to look at in your patients over time. For critically ill patients, especially, this can change from moment to moment, day to day for sure. And this is actually a big thing that I did on all of my ICU rotations that I did both in fellowship and in school, is we went through and you look at every single patient you have on the unit, you look at the changes in kidney function, and you see if any of their meds need to be adjusted for this. Because we know that they're going to have reduced function, we're going to see that you really need to adjust the medications. Many medications require renal dose adjustment. You'll see that if you, one of your medications that you had for your drug information assignment, many of you might have drugs that require that renal dose adjustment based off of changes in kidney function. And so, as I mentioned, you're going to see that increase in serum creatinine as a result of lower GFR is not proportional to that decrease in creatinine clearance. So what does that mean? Basically, that the kidneys function is going down at a pretty steady rate, but that rise in serum creatinine, which you would expect to see, is not quite as fast going up because of the fact they have less muscle mass, right? So less muscle mass means that you're not going to be able to produce enough creatinine. And so you'll see like a little 90-year-old 100-pound patient who has a creatinine of like 0.6 or 0.7, which is 0.8 to 1.2 is considered normal. You may do the calculation like, wow, this patient's creatinine clearance is fantastic. I don't have all that much serum creatinine, but I know a 90-year-old is not going to have that good of functioning kidneys, right? So sometimes you have to make sure you're not, you're sort of not overinflating what their actual creatinine clearance is, because you may be too aggressive in your drug dosing and causing problems for the patients. Or two, like think about your type 2 diabetic patients. You know, if you have a really poorly controlled diabetic patient, you can find that one, they're going to have diabetic nephropathy, meaning their kidney function will go down as a result of their diabetes. But you may have someone with diabetic ulcers that gets infected and they have to have an amputation. What happens if you have an amputation? Well, that is reducing your muscle mass as well. So that can also falsely overestimate their actual creatinine clearance and lead to you being too aggressive in their drug dosing, either in terms of frequency or in terms of the actual dose they're getting. So what happens is you're going to see prolonged half-life, you can see increased risk of that toxic concentrations, and again, this is highly affected by hydration status, right? And again, they don't have a lot of homeostatic reserve as compared to younger patients. So you know, you'll find that you have patients that come into the ER from the nursing home. You know, no one's really watching them that close. No one's monitoring their hydration, their status there, and they stop drinking. Right? They get a cold or something, they don't feel well, and they stop intaking as much fluids, and that causes pretty acute decreases in kidney function to where their drug levels can skyrocket in some cases and lead to some pretty severe issues. I had one patient who was on kind of an old school asthma drug called theophylline, but she had been on it for 25 years. You know, she's 80 some odd years old, coming from the nursing home for seizures. She's not a known epileptic patient, and so she came in seizing, was very difficult to control. We ended up getting a theophylline level because we knew she was on that, and it was sky high. And you know, she'd been on that dose for years, no problem. But one, people weren't checking to see what her kidney function was over time. No one actually looked to readdress her dose. And then two, when she was not intaking any fluids, she ultimately ended up having those levels rise as a result of that, leading to that CNS toxicity and seizures, and she died from that, right? So you got to monitor these patients. You got to look to make sure that that delta, that change in function over time, is addressed and changing their doses as appropriate. See, Pedro says, in the site of action is systemic circulation, e.g. heparins, or if the site of action is the systemic circulation, would protein-bound drugs still be considered pharmacologically active? No, because once it's bound to that protein, it can't really interact with anything else. So, I'm trying to think if there's anything else really to address with that, other than just a no. But yeah, so that's the general rule of thumb: is anything that is protein-free or not protein-bound, unbound, is going to be the pharmacologically active portion. And again, we'll learn about, it's not like every single drug you're going to find is highly protein bound. So we'll learn about certain instances where that becomes important. But just know that if your patients are having sort of an unexpected either increase in effect of the drug or toxicity, it could be related to some of these factors. And this is why you do those laboratory assessments to see kind of what's going on with them, right? So you can double check to make sure that, okay, it's not the albumin that's an issue. Maybe something else going on. And again, just when you're looking at the Cockcroft-Gault equation, not to sort of labor on this point any further, but again, that creatinine clearance may be falsely elevated in some of these elderly patients, because certainly their age, you can't really fudge that too much, but certainly the serum creatinine may be falsely low, and if the denominator is too low, that's going to overestimate what that creatinine clearance is. So you got to be careful with that, right? Any other changes we can see here? So as I mentioned, in terms of drug clearance, the liver flow tends to slow down for many patients, and also you can see increase in risk of things like hepatitis and cirrhosis and things like that can develop over time. And so this can affect things like first pass metabolism, such that maybe you're going to find slowed down first pass metabolism, and now that fraction, maybe if only 10% of the drug were to get through before, maybe now it's 15 or 20%. And so you can see how that may have a dramatic effect in terms of what the patient is experiencing. Bioavailability can go up as a result of this because things are basically slowing down, right? Not only that, but they're more likely to be on medications that can affect things like the CYP enzyme system and slow that down or induce it, as the case may be. So we'll learn about those instances, in the upcoming semesters. So, the question is like with their pharmacodynamics, those are the kinetic changes that we just mentioned there. But in terms of the dynamic changes, how the drug is affecting the patient, we ask, are these patients just more sensitive, right? Is grandma more sensitive to her meds than someone younger that might be taking it? A lot of it has to do with those kinetics, though. So maybe for a given dose of medication, she's just getting much more bang for her buck, so to speak, as a result of her not being able to clear it and metabolize it as well, right? But they also have a lot of lessened homeostatic responses, as I mentioned earlier. Them going from a sitting to a standing position, if they're on antihypertensive medication, can cause some significant orthostatic hypotension that a younger patient may be able to deal with no problem. But they have a hard time being able to deal with that, as we'll see. And so, again, that goes not only with cardiac output and their blood pressure, but also things like temperature regulation tends to go down. This is why, grandma and grandpa always live in a blazingly hot house, is because they can't regulate their temperatures well, and they have a more cold intolerance. This is how I knew my parents were getting old. So when I went back to their house, and I'm like, it's like 78 degrees, and they're perfectly comfortable, and I'm sitting there sweating buckets, right? So that's one thing you'll see with those patients. And just fasting blood glucose tends to trend up due to things like insulin resistance and due to things like the pancreas starting to wear out a little bit. So I want to talk about a few specific drug class examples just to show you kind of how those changes occur in some of these elderly patients here. So talking about sedative hypnotics, what are those? So if you've ever heard of like Xanax or the benzos or benzodiazepines, if you've heard of Valium, these are the sedative hypnotic drugs. We use them a lot either as anxiolytics to deal with anxiety. We use them for muscle relaxers. We use them for sleep in some cases here. So they're sedative hypnotic. They tend to depress the CNS, right? And so you can see that for a lot of these, the half-lives tend to be increased pretty significantly. Why is that? Well, one, it could be related to them not being able to metabolize it as well and clear it as well, either due to hepatic or kidney changes. But you may also see that drugs have active metabolites that tend to accumulate. So it goes to the liver, gets metabolized, and that metabolite has active properties, just like the parent drug does. And those tend to accumulate if they have poor kidney function and things like that. So what ends up happening is you have an increased risk for ataxia, falls, and the altered mental status. A lot of times you're like, okay, well, is grandpa just kind of is his dementia getting worse? It could be related to the medications that are actually taking there in some instances. With analgesics too, which are commonly co-prescribed with sedative hypnotics, which is not a good practice, but it tends to happen, they're going to be more susceptible to things like the respiratory depressant effects, right? And they can also have accumulation of active metabolites. And we'll learn next semester or the following that you want to be cognizant of these elderly patients and the fact they may not be able to clear these drugs as well. And we can actually select specific drugs and avoid other ones in order to get around this, right? So there's certain benzos I'd rather use in elderly patients than younger ones because they get around some of these issues that we're seeing here. We'll talk much more about those. And again, the common trifecta, things that I would see patients come into the ER for due to drug toxicity tended to be an opioid, tended to be a sedative hypnotic, like Xanax or something, and then a muscle relaxant. Just a triple threat of CNS, respiratory depressant drugs all mixed together, and I see a ton of patients come in with that combo. That was prescribed to them normally, but they did not realize how all of those three would be affecting them so synergistically. So other things as well, so antipsychotics and antidepressants, things like lithium, which is less commonly now, but it used to be the gold standard for treatment for bipolar disorder. This one is cleared entirely by the kidneys, right? So just like actually sodium and lithium look very much alike to the kidneys. And so you can find that if you decrease kidney function, you're going to hold on to all that lithium, and that can lead to some significant toxicities. Or things like, if you add diuretics on board too, this can cause accumulation of the drug as well, right? So we'll learn more about that, but this can be a pretty dangerous combo for elderly patients. Antidepressants, this is something that we need to monitor for mental health issues in these patients here, but realize that some of the meds we can use can cause significant change in mental status, can cause significant risk for falls here. And luckily nowadays we have newer agents that help to reduce that risk and have a wider therapeutic index. So we used to use drugs called TCAs, or the tricyclic antidepressants, that were just really, really nasty from a side effect profile, but it's kind of the best thing we had at the time. And now we have things like SSRIs, or selective serotonin reuptake inhibitors, like Prozac and Celexa and things like that, which tend to be much, much safer for those patients there. So again, when you're dealing with elderly patients, you may have a list of drugs saying, okay, these are the drugs I'm more likely to go with because I know they're going to be safer for elderly patients based off kidney function and things like that. There's a list we'll talk more about when we talk specifically about this in Pharm later on, called the Beers list. And the Beers list is not just something you get at the restaurant, but it's actually a list of medications that are known to be quite dangerous in elderly patients due to a lot of these issues. And so you can look that up and see what's on the Beers list, but many of these drugs will show up there. With cardiovascular drugs, you want to be really careful in terms of that orthostatic hypotension that can develop with most of your antihypertensive classes. Not only that, but the electrolyte imbalances can be significant, especially if they're on a diuretic. Mix in with that patients who need antiarrhythmic drugs, so things to treat arrhythmias, like AFib and things like that, can lead to some major issues. And one thing we'll learn about antiarrhythmics, this kind of goes with antiepileptic drugs too, anything that can treat an arrhythmia itself can also cause arrhythmia. It seems kind of oxymoronic to do so, but that's kind of the best. You got to take the good with the bad in a lot of cases. But you're going to find that with the cardiac cycle is really dependent on having appropriate electrolyte levels. And if those electrolytes are out of balance, you have low potassium, or you have high potassium, or magnesium's off, or calcium's off, you can lead to some significant arrhythmias. And this tends to be exacerbated by having these extra drugs on board. So you got to be really, really cautious when doing cardiac meds for these patients here. And so we know that as you increase the number of drugs they're on, you're going to see increase in the number of ADRs that are likely to happen here. And if they don't know what is expected in terms of an adverse drug reaction, they may just think, okay, well, I'm just constipated all the time now, and not realize that it's related to the meds that they're on. And again, if you mix into that patients taking over-the-counter meds and herbal medications, which they may not tell you about, or they may not get your blessing for beforehand, this can also cause some major issues. So, for instance, herbal medication, things like St. John's wort, which is used for depression, can cause significant drug interactions by affecting things like cytochrome P450, 3A4, right? I had one patient who came into the ER for having stroke-like symptoms. She's elderly, and she was had a history of AFib, so she was on the blood thinner warfarin. And then she was worried about her memory going, so she decided to take a herbal supplement called ginkgo biloba. And, it seems innocuous. It's herbal. It's a natural remedy. Well, and some people don't even think herbals really work at all. Well, they certainly can have effects. And so she ended up taking ginkgo for this, not realizing that it also had an anticoagulant effect. So why was she having stroke-like symptoms? Well, when we got the CT back, turns out she had a massive bleed, and she ended up dying from that based on that combination of warfarin plus the actions of this herbal drug she was on. So really ask about these. Make sure you tell your patients, hey, if you want to take one of these, just call us up and get the okay beforehand, because you may find the interaction can be quite dangerous. In terms of prescriber errors too, many prescribers, make mistakes by not taking into account the age-related changes that occur here, by not looking at the renal function over time and those changes, not looking at hepatic function. So that's a big one here. Patient compliance errors. They're forgetful. They forget to take a med, or they take a double dose. When I was doing my fellowship at the Poison Center up in Jacksonville, part of my staffing, quote unquote, was to work on the phones in the Poison Center and get calls from all these elderly patients who would say, "Oh no, I took a dose and then I laid one out for tomorrow, and I forgot that I'd taken the first one. I took a second one. What do I do?" And a lot of times it didn't lead to any issues, but in some cases there were significant issues that we had to send people to the hospital for, because we knew they would have decreased ability to handle that extra dose. Even some double doses of some things can cause major problems. But also they're going to see a lot of providers. So they may see you, say you're working in family practice, they see you for most of their run-of-the-mill stuff, but they have a cardiologist, and they have a neurologist, and they have a rheumatologist, and they're all prescribing medications. And one of the things you're going to find is that, many people don't talk to one another. So a lot of those providers, those specialists, are not going to talk to one another. And you might be that focal person, right? And what frequently happens too, especially with these medication lists that are like 12, 15 meds long, you're very hesitant as a provider to step on other people's toes and change their drugs, right? So you're like, well, I know they're getting a little dizzy when they stand up now, and I know they're on this blood pressure medication, but the cardiologist wrote for it, so I don't want to make them mad and change anything. You do it out of professional respect, but oftentimes you may be that central person, that kind of the linchpin for that patient's care, and you need to be able to talk to that person and call them up and say, hey, I think they're having an issue with this. What can we do instead? XYZ. So this is really, really important. So I really encourage all my students when they're out there and they're working to just pick up the phone and talk to people. It's busy out there, I know, but like you might be that one person that can catch that error and prevent some, down the road sort of bad things from happening to that patient. Especially when like drugs are antagonistic with one another, they're synergistic with one another, it can lead to all kinds of issues. And there's an issue too, like patients may not recognize their drug products as medicine, right? So there's something, and what I've found in the past is that most people from the north don't know about BTC powders or goodies, but it seems to be like more of a southern thing, which I don't know why that is. I think they're sold everywhere in the country, but anyway, so BC powders and goodies, these are marketed for headaches, and basically they're powdered aspirin. They come in this little wax paper sachet, you pour it in your drink, and then you intake that aspirin. And so a lot of people, like, they just don't know that it's aspirin. They don't even look at it. They just know they take a goodies every time they have a headache. And so I had one patient who was at home, and someone had told them, anytime you have chest pain, go ahead and take a goodies. And so this guy was not very well managed in terms of his chest pain, his angina. And so he, one day was having a pretty bad bout of it. So, he had chest pain in the morning, took some goodies. Had chest pain a little bit later, took another goodies. Had chest pain a little bit later, took another goodies. And so then finally he's like, man, this chest pain's not going to go away. I should probably call up 911. So he calls 911. EMS shows up and they say, sir, have you had any aspirin today? And he says no, because to his mind, he has not. So he ends up getting another dose of aspirin. But, no one actually tells them that they're giving him aspirin. So then he gets into the hospital in the ER, and the resident says, hey, have you had any aspirin today? The guy goes, no. So he gets another dose of aspirin. So all of a sudden he's complaining about this ringing in his ears, and everything sounds kind of stuffy, and he's tachypnic, and he's got a fever going on, and they're like, what the heck's going on here? And so someone decides to get an aspirin level, and sure enough, it was elevated. Who would have guessed? So not only was this guy now having an MI that they were trying to work on, but now he had an aspirin toxicity to go along with that, right? All because he just didn't know that this was an aspirin-based product, right? So, these are common things that can happen here. So what can we do? What are some questions I want you to think about asking in order to take a good history from your patients and in order to assess their medication regimens, how they're taking it, what they're taking, all of this. We used to do, back in pharmacy school, we used to do what they call brown bag sessions. And basically we would go to a nursing home, and all the residents would come out with their brown bags full of meds. Time for sodium bicarb. That's exactly what we did. We gave him some bicarb and alkalized his urine and got all that aspirin out. But yeah, we had these brown bag sessions where you'd have these elderly patients come out and they would take out their meds, and it was just like, it was really kind of sobering for me at the time because, I didn't, realize that patients were like this, but they would have meds that were out of date. They would have meds that were antagonistic to one another, that they had kept around for years, even though they weren't supposed to take them anymore. And it was just like, they have the hoarding kind of mentality, many of them do, and they just hold on to everything. So there's stuff like from the 80s. I was just like, this is not any good anymore. Like, what are you holding on to this for? They're like, I don't know what I might need it later. I don't know, which I can kind of see. But anyway, so you want to ask them, are you using drug as prescribed, right? And have them teach back to you how they're supposed to take it to make sure they actually have a good understanding of what they're supposed to do. You can ask, are you experiencing side effects? And it's very easy to say, no, I'm not. But ask about specific ones, especially if there are medications, but they're commonly going to cause certain issues. Like, ask them about it. So say, okay, well, how many times are you having a bowel movement if they're on medications that cause constipation? Ask about, hey, when you stand up, do you ever feel dizzy? Like you might fall down? Usually you want to be specific about asking. And remember, in terms of like communication with patients, you always want to start out with open-ended questions, right? Start open-ended and you get more closed as time goes on. So say like, instead of saying, are you having side effects? Tell me about what side effects you're having. That prevents them from having a yes-no response and opens them up to be more talkative to you. So that's a really important thing there when talking to people, is just start with open-ended questions. If they're deviating from how they're taking it, why is that? Or are they not taking it at all? Like, is it a cost thing? Is it a side effect thing? What is it that they're experiencing there preventing them from taking it like they're supposed to, Are they using any medications not on the list, right? So are they getting medications from other people, or is it medications that, over-the-counter stuff? Are they taking any kind of herbal stuff? These are always things you want to address. And you can say OTC, but, a lot of times people don't know what that means even, right? It seems kind of like, well, who wouldn't know what that means? But ask, hey, do you take anything that you can take without a prescription, or you can get from the store? Things like that can kind of help out and be more specific in terms of getting at, okay, well, are they really taking this stuff or not? Are they taking any homeopathic drugs, herbal supplements, or vitamins? We'll talk a little bit about supplements in our class here, but we'll talk about the regulation of them and how it's really important that, are they taking the same brand every time? Are they being consistent about how they're taking it? All of that may play a role here. They're taking drugs from other people, right? They're getting, some antibiotics from Ethel down the road, right? Are they getting drugs from outside the U.S.? Are they getting stuff online, for instance, or things like that? That could all be important because maybe they're getting it from not very reputable sources, and who knows what they're really getting there. Any meds are no longer prescribed. Are they still taking those? And when's the last time you checked your expiration dates? I'll tell you about expiration dates later, but in general, they tend to be not the most accurate. But we'll talk about when that's important and when it's not later on. But it's good to at least check it out, so that way they're not taking stuff from back in the 80s or something like that. Let's see. So when they're taking medications independently, if not, like who's helping them, right? Who's doing that? Are they using any kind of like dosage system to help them out? If they're using liquid medications, are they using syringes to actually measure out accurate doses, things like that? Let's see. David said, with the big push in essential oils and such, have you noticed frequent interactions? With the oils, not necessarily. There's always the risk. There could be actually something in there. Certain products, especially homeopathic products, that stuff is so dilute that it's very unlikely to really cause any problems there. But certainly with herbal supplements and whatnot, that has been issues in the past for sure. And the thing too with herbals is that they don't have to go through the FDA, right? So there's certain things that they can not say on their packaging. Like they can't say, okay, treats dementia or treats hypertension. They can say supports memory or supports healthy heart, right? And so since they're not FDA approved, there's also not good monitoring on their manufacturing practices and stuff. Because when you get Tylenol 500 milligrams, that's FDA approved. That means that has to have 500 milligrams in there, and there's checks to make sure that they're actually doing that effectively. But if I go to GNC and grab something that says ginkgo biloba, I don't know what the dose is for that, maybe 10 milligrams or something. I don't know what's actually in there because they don't really monitor for that. It's only when reports of like toxicity and stuff that crop up that the FDA really steps in there. But can U.S. providers legally prescribe drugs not approved by the FDA? It's a good question. Generally, no. You're going to find that we generally don't have access to stuff. So you can write a prescription, they can take it to the pharmacist, but they may not have access to it. There are cases, though, sometimes where we actually will give non-FDA approved medications. I'll give you two examples. One I think is more interesting than the other, but with the COVID-19 pandemic that we're in right now, that drug remdesivir, if you've heard of that, it's antiviral, that is technically not approved by the FDA. That's still in clinical trials. Well, who's patients in the clinical trials? Well, it's all our COVID patients. And so we actually had to go through, and you have to go through a special process in order to get those medications there because it is technically not FDA approved. And so it's very tightly controlled, and those patients have to be enrolled in studies and all of that stuff. More interestingly, I have given non-FDA approved medications a couple of times in the case of really exotic snake bites. So for instance, we don't have cobras here in the U.S., indigenously. But what happens if someone gets bit by a cobra because they're a handler? Well, we don't have any FDA-approved medications to treat that, and so we actually have to use things from other countries, and we actually have to make sure the patient's signing all the right paperwork and saying, hey, you're taking this at your own risk. This is not FDA-approved, and we have to make sure we cover ourselves and whatnot. But so we, for instance, like with the cobra bite, there's a South African antivenom we had to give a patient a couple of times. Actually, he's a frequent flyer of ours, but. Anyway, so other questions here you might want to ask, about like inhalational therapy. If it's something that needs or requires technique to administer, like have them demonstrate how they're doing it. If you recall that GIF I showed on the first day of class, that lady who was using the inhaler on her neck, obviously that's improper technique there, but have them demonstrate it to you. You can have patients who have rheumatoid arthritis that have joint deformation that occurs over time to where maybe they can't use that inhaler anymore, right? So maybe you switch them to a nebulizer instead. How are they using eye drops? Any issues with that? Are they keeping it sterile? And this is an important one too. Like if you forget to take your medication, what do you do about that? Like, do you double up on the dose? Do you take 2 the next day? Like for some meds, there are different ways you want to get around that. We'll talk about this. Especially with things like birth control and what you do if you miss a dose of medication, but they may be doing things inappropriately, unfortunately, right? So how are you able to get that antivenom so quick for that specific patient? That's a great question. We didn't want to, get it shipped from South Africa, right? That would have taken a bit of time. The patient would have been probably intubated and kept on the vent that whole time. That wouldn't have been great. And Amazon, unfortunately, was out of stock, and our Prime membership wasn't renewed, so we couldn't do that. We actually went to the zoo. It's actually a regulation for zoos is that they have to keep antivenom for every single snake that they have. So they actually had a stock of them. We had a good relationship with our zoo, and actually for them to keep that antivenom, because it's not FDA approved, they have to have like a medical doctor actually sign off as like the person who makes sure that they're keeping it in the right temperature and they're regulating it appropriately. And so our medical director, Dr. Kunisaki, he was that person for them. He was their antivenom person. And so then when we had a bite that came in, we were able to communicate with the zoo, drove up to the zoo, got the antivenom, and was able to administer it to the patient within a couple hours or so. So that was a fun time getting that stuff. I think I have some pictures somewhere. I might try to get some and show it to you if you're interested. It's just a medication label, but it's kind of cool seeing something from another country. Here's some examples of ways that patients, elderly patients, can help remind themselves on how to take their medications and keep on track. This can be really dangerous. I really hate these things from a toxicology standpoint, mainly because of the fact that if little Johnny or Jenny goes over to grandparents' house, they frequently have not like kid-proofed their places in a lot of instances, and so kids might get into this and open up a couple of them and take different days and times and things like that. And so frequently they'll say, okay, well, they got into this. And I'm like, well, how many did they take? And they're like, I don't know. Yeah, I just know a couple of the days were open, and who knows what's on the floor, who knows what the kid took. So these can be really bad from that standpoint. But for the elderly patients, it's good because it helps keep them on track in terms of how they're taking it. There's apps they can use. There's a million different ways. There's a million different systems out there to help keep them on track there. But when you're looking at obstacles to compliance, you want to think about some of these things. Like medication expense is going to be a huge one. Be familiar, depending on where you work and what kind of patients you're dealing with. Be familiar with what's on the free or the very cheap list at your local pharmacies, right? You'll have a feel for the Walmart list, what's on the $4 list, what's free at Publix, for instance, because that's going to be a major barrier to most of these patients. Think about like arthritis medications. You may have a brand new NSAID that's out that it costs hundreds of dollars, and the rep came by and they served you lunch and told you about how great this new drug is, and they gave you a bunch of samples. And so you give those samples to your patient telling them how great this drug is, but then they can't afford the actual prescription and they can't get any more samples, right? They're not going to take it now. Versus ibuprofen, maybe $10 to $20, for them to take it, and it works just as well for them, or works good enough. That's way more appropriate for them to be on. So think about cost. When you're looking at medication with mixed dosing intervals, try to mitigate that if you can, and say, okay, you're going to take everything twice a day, or you're going to take everything once a day. By having things that are 3 times a day and twice a day, that can be difficult to juggle in a lot of cases here. And think about intelligent non-compliance. Think about patients not taking their meds on purpose, either because they they don't feel good when they take it, so they decide it's not worth it. Because when they come back and you ask them, are you taking your meds right? They're going to say, yeah, of course. And they're just going to lie to you because they're worried about that judgment, right? So you always want to make sure you're kind of fostering a very, one of the things at Nemours where I work, they have these kind of these mottos they go by, or these standard behaviors, behavior standards. One of them is curious and not judgmental. Be curious, not judgmental. And so again, I think that is perfect for all of life, to be honest. But it's be curious about things. Don't just come down like, well, why aren't you taking your meds? Be like, okay, well, you're not taking your meds, that's fine, but how come? What's going on there? Having a better demeanor about that may foster better, more truthful communication. And then, can the patient physically take the drug, right? So this is especially important with, issues of like Parkinson's and things like that, as I mentioned. Try to find dosage forms that are appropriate for them. Should we use a patch? Should we use a liquid? What's going to actually work for that particular patient? So that's it for this section. We don't have much more time, so I'm not going to get into the pediatrics right now. But let me see if there's any questions up on the board here. All right, we have a couple. That's great. Try to blow this up a little bit so you guys can see a little better. Okay, let's see. Are common herbal interactions with drugs on labels or readily accessible via database to providers? In the past, I have seen providers ask about supplements, but then they themselves don't know where there is an interaction or not. Yeah, this is a good question. So we can find interactions there. So I'll show you an example. So one of the things I mentioned, you guys have access to UpToDate. So I think you, if you go to UpToDate and you look up a drug, which some of you may have done already, you'll be able to get to LexiComp. LexiComp is the drug reference I use at work and use most commonly. So you can get access to this through UpToDate just by searching for a particular drug. But there's a section up here called interactions, which is handy, right? So if I do like warfarin and look that up, you can look up certain herbals too. So let me see, ginkgo biloba, right? So I can look that up, and then I can do a search, can analyze for it. As you can see here, it's a D drug interaction, right? So this is basically telling me like this is not a very good drug interaction. D means consider therapy modification. Some things will like be X. So yeah, so you can use certain drug references to look that stuff up. So that can be very handy, and it'll even tell you, okay, what can happen here? Okay, ginkgo can enhance the adverse effect or toxic effects of vitamin K antagonists, severity major, reliability fair, and it can tell you all about it, right? Consider avoiding use of a combination of agents, monitor for signs, symptoms of bleeding. So it tells you what to do essentially. So yeah, that is available. There are other databases which we can talk about at another time, but that's generally what I would end up doing for that. But yeah, I'll find a lot of providers who will talk about it, but don't really have good access to that information or know know anything about it. Yeah, can you explain again the concept of falsely elevated creatinine clearance, increasing creatinine not proportional to the creatinine clearance, right? So that's a good question. So basically what I'm trying to say is that normally if you were to look at, let me see, I'm gonna wow you with my skills again over here. So imagine, if you will, you're looking at a graph here, and so you're looking at a patient in, let's say in red here, we're gonna have their creatinine clearance going down, their GFR actually going down, right? Because I'm using creatinine clearance as my surrogate for GFR. What you're going to see is that the creatinine you would expect to be rising, right? So as the creatinine gets higher, you expect that renal function to go down, right? Because they're inversely proportional to one another. But what ends up happening is that for the elderly patient, that rise is going to be slower because of the fact that they are not producing as much creatinine. So instead of their creatinine, if they had the muscle mass of a 20-year-old being, say, like 2, maybe it's only 1.5, right? And because of that, that same creatinine is lower than it should be based on the fact they don't have as much muscle mass to produce it. That falsely overestimates their creatinine clearance because that creatinine goes in the denominator. So if that's falsely low, overall creatinine clearance looks higher than it should be. And so, like I said, like you'll have patients who are like 90 years old who weigh like 100 pounds, and their creatinine is like 0.6. You're like, okay, their kidney function must be awesome. No, it's not. It's because of the fact they don't have much muscle to actually produce that creatinine in the first place. So what I do in some instances, I'll just bump up their creatinine in my calculations to 1. So at least I'm not overestimating too much, and at least I can not, kind of overload the patient with that medication. So again, we can talk more about that later, but that's generally the idea there. Let's see. Are decreased K levels associated with chronic use of hypertension medications? It depends on the drug there, right? So when we're talking about potassium levels, you can see here that basically depends on the med. Some meds will decrease it, like a lot of diuretics will decrease potassium. Some meds will increase it, like your ACE inhibitors, and there's what we call potassium-sparing diuretics. So this interplay can be important. So it depends on what meds they're on, what their intake is like. So are they getting a lot of foods that contain a lot of vitamin K, or not vitamin K, but actually potassium? You gotta get that confused, just like a lot of my students do. It's probably because I was just looking at warfarin stuff and not because I'm getting senile or anything. But looking at the potassium levels here, you can see that you really want to monitor for that, especially anytime you're adding a new medication on or you're changing the dose of a medication. And so we'll look a lot about this in Pharm 1 and 2 next semesters, in the upcoming semester. So don't you worry about that. We'll talk a lot about potassium. Okay, any other questions or anything from you guys? I don't see anything on the board, at least. I'll talk about the exam next time. I'll put an announcement out if there's any high misses or anything to address with that. Doesn't seem like it, so I'm going to go ahead and say you guys have a great weekend, and I will see you back next Friday. Stay safe out there and socially distant and all that good stuff.